Hello everyone. We're here again with the Hospital Innovation Improvement Network video series. Today we have a short video on the repeat lactate in the SEP-1 CMS Core Measure. Let's start with definitions. The classic definition of lactic acid is something appearing in the blood as a result of anaerobic metabolism when oxygen delivery to the tissues is insufficient to support normal metabolic demands. Now, there is some new research suggesting that lactate levels are actually driven by endogenous epinephrine stimulating aerobic glycolysis, which would contradict the traditional definition. But for our purposes, we're talking more about the clinical effects of lactic acidosis and elevated lactate, and so we can leave the pathophysiology to the side for now. A serum lactate level measures the amount of lactic acid in the blood, and it's a fairly sensitive and reliable indicator of tissue hypoperfusion and hypoxia. And major studies use a cutoff of 2.0 for abnormal and a cutoff of greater than 4 for high. Lactate is produced by most tissues in the human body, with the highest level of production found in the muscle, and normally lactate is rapidly cleared by the liver with a very small amount of additional clearance by the kidneys. Under aerobic conditions, glycolytic metabolism bypasses the production of lactate, and in anaerobic conditions, lactate is produced as an end product of gluconeogenesis. Lactate exists as two isomers, the L-lactate and the D-lactate. We only measure L-lactate because it's the primary isomer produced by humans. The differential diagnosis for lactic acidosis is broad, and you'll often hear this as a critique of why we're using the lactate in the first place. Now, the column A here are types of lactic acidosis secondary to tissue hypoxia. So that is any shock state, septic shock, hypovolemic shock, distributive shock, post-cardiac arrest, regional tissue ischemia, like an arterial embolism, or any anaerobic muscle activity. There's obviously a long column B here that doesn't have to do with tissue hypoxia, things like toxins, malignancy, liver failure, diabetic ketoacidosis. It's important to know that an elevated lactate is not specific for sepsis, but it is fairly sensitive for in-hospital mortality, and that's the reason we use it. Also, shock really is the most common cause of lactic acidosis, so even though this is a very long list, remember. So, why is lactate useful in sepsis care? Quite frankly, it is an independent predictor of in-hospital mortality and becomes an even better predictor of in-hospital mortality when sepsis is present. So sepsis with a lactate greater than 4 has a 30% mortality. Sepsis with low BP has a 36.7% mortality, and if you have a low blood pressure and an elevated lactate, you're up to a 46% mortality. So these may easily be the sickest patients in your clinical arena at any given time. So you should really pay attention to an elevated lactate. The role of serum lactate in the 3-hour and 6-hour SEP-1 core measure is pretty simple. In the 3-hour measure, you want to measure an initial lactate, and if that lactate is greater than 4, that is a marker of end organ damage, and that puts the patient in the severe sepsis category. In that category, your patient is going to receive a 30 cc per kilogram bolus of crystalloid for hypotension. In the 6-hour bundle, you want to remeasure the lactate if the initial lactate level is elevated greater than 2. And this is one of the more tricky parts of the measure to operationalize, and so we'll talk specifically about strategies to get that repeat lactate measured within 6 hours. Now, there are always naysayers, and no test is perfect. These are the top 5 lactate critiques that I've heard as I talk to clinicians around the state of Wisconsin, trying to get their information on how they're operationalizing the CMS core measure. Some say that it's a nonspecific test with a broad differential diagnosis. Why are we relying so heavy on this? I've heard it called cookbook medicine. Let's use clinical judgment instead of this lactate test. I've heard people say that the venous lactate is not useful in the first place, and we should only be testing lactates based on arterial draws. I've heard people critique the cutoff of 2.0 as too low, and that we're getting too many false positives. What do we do with this information? Are we putting ourselves at medical legal risk? And then I've seen some infighting when the repeat lactate isn't being drawn. Whose fault is it? Is it the ED's fault? Is it the transition of care team? Is it the ICU? And we'll address each of these issues. Critique number 1. It's a nonspecific test with a broad differential diagnosis. Well, that's true. But the lactate is a screening test, and it's designed to cast a wide net. So we expect false positives, and we allow for false positives. Let's look at the numbers of an elevated lactate even without sepsis. If your lactate is between 0 and 2.5, so essentially normal, you have a 4.9% chance of in-hospital mortality. If it's elevated, even in that 2.5 to 4 range, you've now doubled your chance of in-hospital mortality, up to 9%. If it's greater than 4, the chance of in-hospital mortality is 28.4%. And that is 55% sensitive and 91% specific for death within 3 days. So even if you're not using this lactate in terms of sepsis, let's say you have a diabetic ketoacidosis patient with an elevated lactate, that's still a very sick patient with a very high risk of mortality. Is that not useful information? Wouldn't you want to know that? Obviously, there are specific situations where maybe a lactate causes a delay in clinical care, or somebody has to stay later for the repeat lactate. But in general, I think this is very useful information to have. In response to the cookbook medicine argument, occult sepsis is very real, and loaded terms like cookbook medicine are pretty much distracting. We routinely protocolize disease screening based on risk factors in medicine, and the use of clinical judgment is very important, but I would recommend that we actually use it to interpret the meaning of an elevated lactate rather than the idea of whether to send it or not in the first place. Lactate is very useful for detecting patients who have occult shock, and patients who are maintaining their blood pressure due to vigorous and endogenous catecholamine responses may have deceptively reassuring vital signs. That might mask the fact that they're actually in a catecholamine-dependent shock state. Elevated lactate identifies these patients as having an increased risk of death or decompensation, and thus require more aggressive management. Although most often associated with sepsis, occult shock with elevated lactate may be seen with any cause of shock. So, is this really cookbook medicine, or is this a clue that can have us use our clinical judgment even better? Now, some people villainize the venous lactate, and it is true that if lactate isn't measured within 15 minutes, you can start to get elevated levels. But this article, or these two articles below, studied this thoroughly, and peripheral venous lactate levels are highly correlated with arterial blood lactate levels, and either method can be used. Also, tourniquet use during blood draws and the routine use of ice for transport do not affect lactate levels, and provided that the samples are measured within 15 minutes and using a point-of-care device. If in your organization you are finding a discrepancy between arterial lactates and venous lactates, make sure that once the lactates are run down to the lab, both are being run on a point-of-care device machine like an iStat machine. If you're using your analyzer for serum lactates, depending on the analyzer, there might be a discrepancy. And so that's an area for quality improvement. Why are we using 2.0 as the cutoff? It's only meaningful after 4.0. This is actually a valid argument to make. Anytime we use a screening test, we want to balance the benefits, like not missing the disease, with the risks, over-treatment, complications of treatment, etc. In the case of sepsis, a conservative cutoff was chosen, and as we get more experience with the SEP-1 measure, that cutoff may well be adjusted by the experts. But for now, let's err on the side of a conservative cutoff and let the experts adjust it as we get more metadata on these outcomes. Finally, the repeat lactate didn't get done. It's the ED's fault, it's the ICU's fault, it's the hospitalist's fault. The simple answer here is that patient care should trump egos and hospital politics. Easier said than done, I know. We have all had experiences where disagreements above staff led to less than best practices in terms of patient care. The AHRQ and other quality organizations offer tools like team steps that can help move the conversation away from finger pointing and towards teamwork. The most important first step is to identify a clinician champion from each clinical arena who really believes in the importance of the repeat lactate and have them regularly attend the sepsis meetings. When you have a shared goal and key influencers on board, implementing multidisciplinary protocols becomes more realistic. Here's a few bonus questions I've heard a few times. Is the lactate level accurate in renal patients? It is. Lactate is primarily cleared by the liver, and an elevated lactate in end-stage renal disease still predicts in-hospital mortality. Lactated ringers can be used as a resuscitative fluid. Lactated ringers contain sodium lactate, not lactic acid, and they are therefore not acidotic. So you can use LR as your crystalloid solution. And finally, it's one of these dogmas of medicine that epinephrine shouldn't be used as a vasopressor in elevated lactate shock states. That has been debunked, and epinephrine is an effective vasopressor for septic shock. Our understanding of why this works is evolving and currently under investigation, and so as we flesh out the details, we'll let you know. Finally, if you have additional questions or if you want more resources, please visit the WHA Quality Center or the Michigan Hospital Association community page for more information, and we'll see you on our other videos.